Well, we'll get started on time here so that we give all of our time and don't miss out on our wonderful speaker tonight. So first, I get the benefit of being able to introduce yet another wonderful opportunity for us to have this GU and University of Washington partnership. And so our UW-GU Health Partnership, yet another annual. I'm trying to think of how many we have within a year. So actually I shouldn't say annual, but so 3. Triannual kind of our gathering together. So I'm Dr. Julie Walter. I am the Dean of the School of Health Sciences here at Gonzaga University, and I get to work with many of my fellow colleagues at University of Washington and their fellow assistant and dean roles through, again, this UW-GU partnership. And so before I introduce our esteemed speaker, which Dr. Jeff Johnson will be, or Jones, sorry Jeff, will be doing for us tonight, I wanted to just give a little bit of an overview of what is the UW-GU Health Partnership. The partnership has been going on officially since 2016. And then we recently, within the last couple of years, were able to move together into a beautiful building. Many of you see the big white building that you pass by coming to main campus of GU, which has really given us the opportunity to think about new and innovative ways that we partnership. So the partnership itself is based on the 50 years of amazing history in research, which we're going to be hearing about a little bit today, through University of Washington, as well as then the community foundations and leveraging also the undergraduate and graduate programming in health sciences that's complementary to our UW partners through GU. And again, our new building enables us to think of new ways to be perhaps sharing faculty. So for example, we have faculty that teach our human anatomy physiology courses to our med students through the UW School of Medicine that are also on faculty at GU teaching anatomy and physiology for our undergraduate human physiology students. So we have a lot of programming such as some of the research with now our new program, and department for public health, and our new graduate of public health is coming online in fall through GU. And those provide also opportunities for our med students to work and research alongside our undergraduate public health students who are also going out into, for example, some of our rural and underserved communities and thinking about how we can partner long-term and do some really cool experiential learning. So those are just some examples of some new opportunities for how we are partnering together, again, at GU with the Research One expertise that we'll be hearing about tonight through University of Washington. So I am going to hand over the microphone to my fellow colleague, Dr. Jeff Jones here, who will then introduce our esteemed speaker tonight. Thank you, Jeff.
Yep. Yeah. All right, so like I introduced myself before when the students were here, I'm Jeff Jones. I'm Assistant Clinical Dean for Spokane and Eastern Washington. I'm a family physician up in Newport. We've been there 22 plus years, and before that I worked for a little bit in Western Alaska. And first, before I forget though, I do want to thank our sponsors, Providence Multicare, Spokane County Regional Health District, Spokane Medical Society, and the UW Population Health Initiative. We really feel we are stronger together and that we can do more together rather than working separately and competitively. So what we're going to do here, Dr. Hirsch is going to talk for about 45, 50 minutes. We want to leave time for like a really good, robust Q&A session. There'll be opportunities for folks here and then folks online as well. Rumor has it there's about 200 people watching online too, and so we'll try to get some of their questions as well. There'll be a panel discussion after that. Annika Van Sloten, who's a nurse practitioner and diabetes educator, will be up here, as well as Dr. Carol Weisham, a current and soon retiring endocrinologist here in town with MultiCare. So we're really pleased this evening for our featured speaker, which is Dr. Irl Hirsch. Dr. Hirsch from the University of Washington. He is an expert on diabetes and was one of our featured speakers in 2023 when this was apparently all Zoom and not in person, which feels really kind of strange to me now. In that lecture, he talked a lot about type 1 and type 2 diabetes, and tonight he's going to share the latest news in diabetes research, especially in regards to CGM, or continuous glucose monitoring. As you saw in the Camp Sticks pictures, there's some nice photos of everybody showing off their cute little CGMs up there right in the middle. And why this has become just a huge, important, popular tool for managing diabetes. Dr. Hirsch has dedicated his career to patient care, to clinical research, and teaching. His focus in these areas is in the treatment and management of diabetes. He is a full professor and the Diabetes Treatment and Teaching Chair at the University of Washington School of Medicine, Seattle. He's a professor of medicine in the Division of Metabolism, Endocrinology, and Nutrition. Dr. Hirsch received his medical degree from the University of Missouri School of Medicine, completed his residency in internal medicine at the University of Miami in Miami, Florida, and then Mount Sinai Hospital, Miami Beach, Florida, and a research fellowship at Washington University School of Medicine in St. Louis, Missouri. He has authored more than 200 research papers, including a review of insulin in the New England Journal of Medicine. He has also written more than 60 editorials, 3 commentaries for the Journal of the American Medical Association, numerous book chapters, and 4 books for patients and clinicians. Additionally, he is the former chair of the Professional Practice Committee for the American Diabetes Association and has served as editor-in-chief of 2 ADA journals, Clinical Diabetes and DOC News. He has also served as a member of the American Board of Internal Medicine. From both a research and teaching point of view, Dr. Hirsch has spent his career studying the best strategies for the use of insulin therapy and better technology in both type 1 and type 2 diabetes. He has been an outspoken advocate about insulin pricing in the United States. And with that, please welcome Dr. Irl Hirsch.
Thank you very much. Appreciate the introduction. I guess you can bring my slides up. You know, every time I come to Spokane, and this is no exception, I have so many wonderful memories about Spokane and this side of the state. And I'll let you fix the slides. And I've known Dr. Weisham for years, many other friends over the years here. Great. But what really stands out to me has been my longstanding relationship with somebody who's not here tonight, and that's Keith Campbell. Raise your hand if you knew Keith. Yeah, a lot of you. Keith was an inspiration to all of us, and I miss him, and I'm thinking of him tonight. And my guess is he's watching, and he's going to give me some comments later. I'll dream about it or something, but Keith was a wonderful friend. I was asked to talk tonight about continuous glucose monitoring. Now, I know not everybody in the room has diabetes, but if either you or your loved one is using a CGM right now as I speak, raise your hand. It's almost everybody. It's not everybody. So where I want to start is I want to take a trip down memory lane. How did we get to where we are now? Now, I was very impressed by the medical students with Camp Sticks. So, full disclosure, I've been doing this for 61 years, okay? I remember what it was before we had the finger stick glucose testing. And I want to show you a little bit about this. I mean, this goes back even before the discovery of insulin. We've heard of the Benedict's test. Well, there was a guy named Benedict, and he developed this chemistry for how you could look at glucose in urine testing. And that chemistry that he discovered lasted for 50 years. Insulin was discovered in 1921. First insulin was injected in January of 1922. And then in 1945, this horrible, cumbersome method for doing urine glucose tested was replaced by not having to do a chemistry experiment, but by using something called clinitest. Raise your hand if you remember clinitest. There are a lot of people in this room. So you could measure the glucose by looking at the color that it changed from this chemistry reaction. And this is something I found online. Her name is Elizabeth Hughes, and she was one of the first people to receive insulin. She was the daughter of then Secretary of State. And she was one of the first people in Toronto to get insulin. Note, this was in 1922. It was in the summer. It was in August. She started insulin, and she weighed 45 pounds. A few weeks later, she was up to 54 pounds. And you could see everything that she captured. You can actually see it better on the screen than I can see here. But capturing the urine glucose, what she was eating, the amount of insulin she was giving. Folks, there were no apps in those days. This is the way she did it. And then in the 1930s, it got a little bit more sophisticated using this Benedict test, but not really. And then into the 1940s to 1960s, there was this Sheftel urine glucose test. It was urine sugar based on a method devised by this physician named Abraham Sheftel. And he invented it in New York, but of course, Eli Lilly got all the profits. That's how it usually works. Hasn't changed today. And this is what it looks like. Anybody in the room use this? Nobody in the room used this. Because usually if I show this picture, this brings back a lot of memories, not good ones. Because what you had to do is you had to put the blue pill into the test tube with the urine and the water, and then the white pill you put underneath it, and then you had to put a match to it and burn it and see what color it would change to. That's a long way from CGM. This is what most people, raise your hand if you used the clinitest. Yeah, now we're getting into more modern day, 1960s to the 1990s. That's blue. That means there's no sugar in the urine. 1978, the Ames iTone. And it was very interesting. This whole history is fascinating. This was started by a gentleman who's still alive today. His name is Richard Bernstein in New York City. Everybody thought he was nuts. He was a medical student in his 40s. And he believed the only way to do this is to check your blood sugar at home. And the doctors thought he was crazy because everyone knows the only one who can check the blood sugar is in the doctor's office, right? Maybe once a quarter. And this first iTone glucose monitoring system, you had to put the blood from the finger stick on the strip, you had to wait, you had to wash off the blood, and it was pretty messy. And then in 1980, this dextrometer came out. Again, full disclosure, this was the year I started medical school. And it was, I remember this very well because the cost of the meter was $500. In 2024 dollars, that's $3,700. But that wasn't what was so interesting. What the company that made this thought, what their business model was, we would sell these meters to the doctor and we would make the money from the meters, not from the strips. Nobody thought that you would make money from strips. Well, they soon figured that out. They had their business model all wrong. Now, what made this all possible in the early 1980s? Wait a minute. What do I have, a guillotine? Oh, that's why. How many of you remember this? Yeah, a lot of people remember this. This is what changed glucose monitoring completely. It wasn't that it wasn't painful, but it wasn't as bad as trying to poke your own finger. This was the very first one. And this was revolutionary at the time. You put the blood on the strip, you would see the strip, and you would compare the color. But of course, you would see it wasn't very accurate if 80, 120, 180, 240. It was interesting how most patients would always sort of guess to the lower number than to the higher number. That's how it was done in those days. But of course, if you were a poor college student, you would cut them into thirds. Okay? This was really expensive. And later, years, decades later, we learned what the profit margins were on this. This was a huge business. And then, of course, it became a commodity. Many of these glucose meters today, so many stories to tell about this whole business and business model, but that's not why we're here tonight. But I do want to say, let's not forget the significance of self-monitoring of blood glucose. And by the way, that molecule in the background, that is a glucose molecule. The medical students knew that. But accuracy, the amount of blood required, new chemistries, all resulted in better decisions, especially for insulin dosing by the patient, because it was really, no pun intended, a shot in the dark when all you had was urine. The urine was really not helpful at all when we look back on it. It took years to develop the evidence for the fingerstick glucose testing, even in type 1 diabetes. It took years before the insurance companies would cover the strips. In 1990, my first year at the University of Washington, I will never forget this. My second patient I saw, I don't remember if it was a man or a woman. I don't remember if it was a type 1 or a type 2 patient, but I prescribed a glucose meter. And literally the next day, the patient's primary care physician called me. I remember his name, and he started yelling at me. Why would I prescribe this expensive device that hurt the patient, that was expensive, and there was no evidence that it made any difference at all? So there was this big push not to know what one's blood sugar was. In 1990, literally my first week at UW, this is what happened when I arrived. And then, of course, this huge study, which we are still doing, the Diabetes Control and Complications Trial. This was the study that reported in 1993, yes, if you aggressively treat the blood sugars, you can prevent or slow the progression of eye disease, kidney disease, nerve disease, and later we found out you could actually prevent cardiovascular disease with this early aggressive therapy soon after the diagnosis, in this case, type 1 diabetes. Later, there was a study from the UK that essentially showed the same thing for type 2 diabetes. But before 1993, we did not know that taking care of the blood sugars made any difference or not. So much more rational use of insulin in the hospital. And I remember this very, very well, of all the controversy of doing the finger sticks in the hospital during my training. And I remember when I was at the University of Missouri, we would use the finger sticks to help us decide what insulin to give. But then when I went to Miami, that wasn't the case, because the laboratory was losing all this money from not taking the glucose to the lab, which it would take an hour and a half to get back. And by that time, the food was eaten, the insulin was given, and it didn't matter. Huge controversies that most people today don't even know about. But cost remained then and today a major barrier. And then in 1997, I went to Olympia, Washington to work on this American Diabetes Association sponsored Cost Reduction Act. And what this act was, it was to force the insurance companies to pay for the strips for people taking insulin, including children. Because before 1997, the insurance companies, you had to fight to get the strips. Now, this wasn't that long ago. The good news is we won, but it really made me think differently about the insurance companies when I went head-to-head against them in Olympia, Washington. Now, fast forward to 1999. This dapper gentleman is Mr. Al Mann. Many people know Al as the gentleman who started insulin pump therapy, and he was the one who started MiniMed, which today is Medtronic. But I went to a meeting, it was actually in Honolulu. The American Diabetes Association in those days had their post-grad courses in Hawaii. They don't do that anymore. They should, just my own opinion. But I went to this meeting. There weren't many of us there, maybe a dozen of us, and he showed us the first 3-day, he called it CGMS, Continuous Glucose Monitoring System. We don't use S anymore. The S was part of this original device, and it was later approved at the end of '99. I learned about this in January of that year, and this is what it looked like. And with this very first device, you couldn't actually see the glucose. It was blinded. You would wear it for 3 days, you would then bring it back, and the doctor would download it, and you would go over the results together. There was nothing real time about it. And just getting that through the FDA was a really big deal. And I will never forget my very, very first patient on this. He's still with us today. He's 82 years old. He's had his diabetes over 70 years, and he wore this over the Thanksgiving weekend. And it was Black Friday, and he didn't know he was hypoglycemic. He was going the wrong way on Highway 90 on Mercer Island. And I had the hypoglycemia captured. And I realized then, this is going to be a big deal. How does this work? Well, it's really easy. You have glucose in the fluid. It's not in the blood, but it's in the fluid under the skin. It's combined with the water. There's an enzyme called glucose oxidase, and by the way, this is how many of the fingerstick glucose meters work. It makes this chemical. Now, what this chemical is, gluconic acid, isn't important, but what is important is the hydrogen peroxide, because that can cause all kinds of interferences, for example, with Tylenol. But what's important about the hydrogen peroxide is the amount of hydrogen peroxide is in that interstitial fluid is proportional to what the blood sugar is, and that can then go and give you a glucose reading on your CGM. It's this very simple organic chemistry equation. So we started getting more of these CGMs. The very first Dexcom was called the Dexcom STS, and I will never forget a gentleman who I know some of you in the room know, Andy Balo, comes to my office with Andy Raisdow, who at that time was the president, and said, we're going to do this STS just preliminarily, this subcutaneous glucose sensor, because what we're really going to do is an implantable sensor. But we're going to put that on hold for a few years. Well, that was in 2006. Dexcom still doesn't have an implantable sensor today. But this is what Dexcom sensor looked like then. And then in 2008, we had the Dexcom sensor. Abbott had what was called the Navigator, which does not exist today. Medtronic had their first sensor. And the reason why I'm showing you these three sensors is that University of Washington was part of a clinical trial with children, adolescents, and adults. There were only 3 of us who did the adults, and we were one of the adult sites where we would put patients on these sensors. Most of these patients were wearing pumps, but not all of them, and we would see if the hemoglobin A1C levels were reduced. And this was a big deal because we knew that there were 2 insurance companies, one of them was United Health actually, that they told us, if you can show a reduction of hemoglobin A1C, we will cover the sensors for our commercially insured patients. And so we did this study. We presented it, I will never forget this, we presented it on October 2nd, 2008 in Rome, Italy, and it was 2 o'clock in the morning here, and I was so excited because I presented this study that was published the same day in the New England Journal, not the same day, the same hour. It comes out, and what we showed was it really did lower the glucose. The control group was wearing a blinded CGM. The CGM group, they were looking at it real time, and you can see at the bottom at an A1C of 7, there were only about 10% of the control group, whereas with an A1C of 7, there was over 40% of the CGM group that were at 7. At 8%, it's even more interesting. At 8% with the control group, it was maybe 50%, but it was well above 80% in the CGM group. And at 26 weeks, the A1Cs were lower with CGM by over 0.5%. What that meant was many of our patients with these national insurance companies started getting coverage for the CGM, but interestingly, here in Washington State with our major carriers, not Medicaid and Medicare, but the commercial carriers, it wasn't until 2014 that we had pretty much universal coverage. I mean, technology takes a while before it gets covered. And what was really interesting, which we were not allowed to put into the New England Journal paper, but we published the next year, was the fact that the adolescents and the children did not show a reduction of A1C. And that should surprise people, but the reason why is that we had 165 with A1Cs above 7, and if you look at it based on how often they were wearing the sensor, what you see is in the, I guess the pink, is that whether they were above 25, 15 to 24, or 8 to 14 years of age, if they wore it 6 or 7 days a week, they had this tremendous drop in their A1C. If you wear it, it works. If you don't wear it, it won't work. It's not that complicated. And we weren't allowed to put this in the original article, but this is a big deal. It's like anything. If you take insulin, your blood sugar will go down. If you don't, it won't. It's the same with this, okay? So here we are today with all of these different CGMs on the market, and we certainly have come a long way. Now, as a patient, what do you need to know about the downloads? Raise your hand if your provider reviews your glucose download with you pretty much at every visit. Very few of you. Very, very few of you. Okay, it's important that you know this. You see this time and range chart. Time and range is, there's only 2 different time and ranges. Well, maybe 3 now, but we'll say 2. 70 to 180 is really the only time that counts, with the one exception of pregnancy. And then it's 63 to 140. Other than that, even though you can change it on your app or you can change it on your computer screen, 70 to 180 is in range, below 70 is below range, above 180 is above range. Those are the numbers you need to know. And you want that time and range for most people, but not everybody, you want it above 70%. So that's the target. The time below range, I personally think this is too high of a number. It comes from the first Medtronic 670G study, where they could get the time below range less than 4%. 4% is about an hour a day hypoglycemic. I want to get this changed, and this is one of the things I hope to do in the next year or two, because I believe 4% is too high. Time very low, we don't want any time less than 54. That's really getting down there. Now, what else do you need to know? Well, you need to, averages are important, but this is more important. The estimated A1C, and you'll see why it's really important in a minute, but everybody has this glucose management indicator on your app or on your download. If your doctor downloads it, you see the GMI. It's estimated A1C. The FDA did not allow estimated A1C, so we had to call it something else. And all this is, it's a mathematical equation that's based on your average glucose. And it turns out this has taught us so much about A1C because the A1C and the GMI don't always match each other. Has anybody seen that? Yeah, everybody. That's important. Now, there's a glucose variability number called the coefficient of variation. The percent coefficient of variation, it's a measurement of glucose variability. As a rule of thumb, the less insulin one makes, so everybody with type 1 diabetes, the more difficult it is to keep it low. Therefore, in general, type 1s have higher CVs and more variability than type 2s, and type 2s on insulin have higher CVs, and the reason is because they're making less insulin, and that's why they're on insulin. And the CV turns out to be a really interesting metric to look at if you're interested in it. So, what should the target CV be? I mean, we have these targets for everything. Well, as it turns out, it depends who you ask. We don't have a consensus on this point. In general, the higher the number, the greater your risk of having a bad low blood sugar. We do know that. And general things to think about, having a coefficient of variation between 28 and 30, but a high average glucose. So you have a high average, but a relatively low coefficient of variation. That is somebody who's making insulin with high numbers. That's possibly somebody with type 2 diabetes who needs more therapy, possibly insulin therapy if they have a high average and a high A1C. Or it could be a type 1 who is completely terrified of hypoglycemia and they are always defending their blood sugars against hypoglycemia. And we see this in our clinic every day. What about a high percent coefficient of variation, above 36 or above 40? Well, this is somebody who's late or missing their mealtime insulin. We see this a lot. And now with automated insulin delivery, and raise your hand if you're on an AID, automated insulin delivery system. There's a few of you. Okay. We see this in our clinic every day. Coefficients of variation under 30, under 26. A few years ago, that would have been unheard of. But that's how good this technology has gotten. So the new metric, remember I said there are two things you need to know? Well, this is the other one. Time in tight range. It hasn't caught on yet. It may or may not. The time in tight range window is 70 to 140, and it's not yet on the downloads. We haven't had any consensus if we need it. But in reality, whether you're looking at type 1s not on AID, type 1s on AID, or type 2s, the curves look pretty much the same. And a 70% time in range is give or take about a 45% time in tight range. I don't know if we need one more thing that can confuse people. I haven't convinced myself yet. Now, ambulatory glucose profile. This is very popular of a way to look at where are you having problems. Now, look at this person. You see what that ambulatory glucose profile shows in the middle? That in the late morning, you see that big giant spike there? Well, let's think through this. There's the spike. The rest of the day, this person looks pretty good. The time in range isn't where maybe it should be, about a 65%. It's not horrible. The percent low is very good for somebody on insulin. Coefficient of variation, not bad. The estimated A1C or GMI, 7.3%. It's okay. And you look at this and you think, well, what should I do with this person? Well, here's the thing. Is this one of the 12-year-old campers at Camp Styx? Is this somebody getting ready for pregnancy? You need to know a little bit about the patient. And as it turns out, this is somebody with type 1 diabetes on basal and bolus insulin. And as it turns out, this is an 83-year-old woman with 65 years of type 1 diabetes who has oatmeal and raisins every morning for breakfast. Okay? Knowing that, what do you say? Enjoy your oatmeal. That's what I told her. And this is what she looks like every download. Very, very consistent. So, continuous glucose monitoring today. American Diabetes Association say this is level A evidence. We have randomized controlled trials. Whether you are a type 2 on basal insulin alone or a type 1 patient on basal bolus insulin, if you are on insulin, you should be on a CGM. And in fact, Medicare covers this if you are on insulin, even one shot of basal insulin. Now we have over-the-counter CGMs that arrived a few months ago for people not on insulin. In fact, people with prediabetes, in fact, people without diabetes like to wear these to see what happens to their glucose with certain things they eat, with their exercise, and so forth. By the way, we don't have evidence for that last one, but people like to do it. What do we know about CGM users today? Well, this is where it gets really interesting. This is from the T1D Exchange Collaborative. This was published in 2023. This data is really from 2021 and 2022, but it was 11,000 people with type 1 diabetes. A little under half were using CGM if you looked at these 11,000 people from all over the United States. And what you see here is that the group with the most were the 27 to 55-year-olds, and the least were the 13 to 25-year-olds. Perhaps not surprising, but the numbers were relatively low. When you look at race and ethnicity, the non-Hispanic whites were the best at about 50%, but the non-Hispanic blacks were down at about 15, 20%, very low. And then if you look at insurance, not surprising, the private insurers were the best at about 60%. So there are inequities on who gets to use CGM. And where you live and whether you have Medicaid expansion, fortunately we have that here in Washington State, it makes a big difference who has access to this amazing technology. What about continuous glucose monitoring and type 2 diabetes? We published these data from the Optum RX data set a few months ago, and it's pretty interesting. The NIT on the left is non-insulin users, BIT is basal insulin therapy, PIT is prandial insulin therapy, so that's basal bolus. And what you can see is going from 6 months before they got their CGM, and this was almost all Libre and Dexcom, to 6 months, or actually 12 months afterwards, there was a 10% reduction in hospitalizations for people not even on insulin therapy. For people just on basal, it was almost a 14% reduction in hospitalizations and almost a 23% reduction in hospitalizations if they were wearing CGM for 1 year. And it wasn't just hospitalizations. We saw the same kind of trends with hemoglobin A1C levels. And the one that to me is the most important one here is the bottom curve, the blue curve, because there was this reduction of A1C from 8.6% to 7.5% just wearing the CGM, nothing else. This is a powerful, powerful tool because they're doing things differently. What about the future? Well, there are 4 CGMs on the market, and there are other companies with traditional CGM in development. And this is not a complete list, and there are other companies I'm sure I don't even know about. But what about non-invasive CGM? This is really the holy grail that so many people have been interested in so many years. You can see what these light ray looks like going from the gamma rays at the far left to the radio frequency on the far right. The radio frequency is the longest wavelength. Well, why is that important? Because there are people using infrared and microwaves and radio waves to try to figure out a non-invasive CGM. Using optical technology, infrared or RF waves, radio frequency, you could theoretically use the interstitial fluid like we use now, but what if you could measure just the blood glucose on the back of your Apple Watch? That would be pretty cool, wouldn't it? Well, there are many companies working on this, putting a lot of effort into this. And note there are really 2 kinds of companies there. There are medical companies and there are technology companies. I mean, Apple has been working on this for 20 years, and they're still working on this. And I'll tell you what concerns me a little bit about that. Let's say a company like, oh, I don't know, you could pick your company, Microsoft. I live down the street from Microsoft. My concern is that if Microsoft comes out with it, it would never go to the FDA so you could use your sensor to dose insulin. That's not what I want to see. But we don't know what's going to happen. Now, I know these people now, but I don't work with them. They're in Seattle, no labs, and the point is that their MARD, mean absolute relative difference from the control, is 11%. As a rule of thumb, we want the MARDs to be under 10%, but this is really good for their first attempt. And the reason why it's so good, remember that Dexcom STS I showed you? Those first sensors were around 20%. So this is not bad at all. Now here's another company. Now this one I do know about. This is a company I work with, full disclosure. They are in Israel. And as you can imagine, things have not been moving quickly with this for the last year because of the conflict. I'm hoping now with the ceasefire, we will hear more from this about the G-Wave. And it uses the radio frequency to measure the blood glucose. The blood, not the interstitial glucose. And we published this data last year, and this is looking at an air grid where you want everything to be in the zone A or the zone B, and we had 97% in zone A. The big caveat about this study is that this was early in the development, and at the time, it only went to 180. But suffice it to say, doing the entire window of what we see in diabetes should be possible. But I want you to pay attention to the hypoglycemia you see on the left part of the screen. And the reason why that is so interesting to me, this is me. This is literally me. What I did was, over the Memorial Day weekend of 2023, I went to Israel. I started with a blood sugar of, you can see it, of around 160, 170. I was using a G6. I was also wearing a Libre 3. The red is the finger stick. The blue is the G-Wave. And note how the finger stick and the G-Wave are right on top of each other. And they should be right on top of each other because they're both measuring the glucose as the glucose level is falling. Now, the problem when the glucose level is falling, and I was running all over the campus to get the glucose level down, but the reason it's falling and the reason why they're on top of each other is they're both measuring blood, but look at the Dexcom and the Libre 3. The Dexcom and the Libre 3 are measuring interstitial glucose, and because of that, there's that lag time. It's that lag time that drives us crazy because you know the blood sugar is low, you feel it, but the sensor isn't saying it's low yet, even though you have an arrow going down. It says it's 110. Well, that's because of the lag. There's no lag here. That, I think, is pretty cool. More learnings from CGM. The impact of race. So we, at an age, CGM has taught us more than how to take care of diabetes, how to prevent hypoglycemia, how to lower the A1C. It's actually taught us about A1C by itself. Now, if you just look at the blue and the red, the blue are those who are white, the red are those who are black. At any given glucose, white people have lower A1Cs than black people. Now, we've known this for some time. This is not new, but on average, the A1Cs for black people for any given glucose run between 0.4 and 0.5% higher. Well, that's interesting, it's important, but look at this comparing the young people in blue compared to the older people in red. You don't need to know statistics. The only way you don't understand this is if you're colorblind, because what it shows is that at any given glucose, the blue, which are the 18-year-olds or less, at any given glucose, their A1Cs run lower than the older adults that are red in this picture. In other words, it's easier to get a lower A1C when you're 15 than when you're 65. Did you know that? It's kind of interesting. Now, what we did in Seattle, and I did this with a resident at the time, is we looked at our CGMs 25 days, we looked at their A1C, we looked at their GMI, and look at this variability between the mean glucose on the CGM compared to the A1C. I mean, these people are all over the place. I mean, you can see someone there on the far left with an A1C of 11.5 with a mean glucose under 100. I mean, this is what we see in our clinic, because in our clinic we see people with kidney disease, we see people with liver disease, we see people with all different kinds of anemia, we see people undergoing chemotherapy, and if you just look at a population, you would say the mean glucose doesn't always correlate with the A1C very well. And as a matter of fact, the two are only the same 11% of the time. And as a matter of fact, and other people have shown this, we aren't the only ones, half the population, there is a 0.5% discordance. What does that mean? It means if your GMI, if your estimated A1C is 7%, your laboratory is going to give you an A1C 50% of the time above 7.5 or below 6.5. 50% of the time it's going to be 0.5 off. And not only that, 22% of the time it's a point off. What that means is if your estimated A1C is 7, the lab is going to say it's above 8 or below 6. 22% of patients. Scary. And now what we're playing with in Seattle is this ratio. Now this is a little complicated. The ratio itself is easy. It's just the GMI, the estimated A1C, over the A1C. It makes a ratio. And this is what we found. If the A1C is consistently higher than the estimated A1C, and that makes the ratio low, we found that that is a predictor of eye and kidney disease at any given glucose. So if you go to the doctor and you look at your GMI and your A1C is always reading high, that may not be a good thing because the A1C is reading high. By the same token, if the A1C is consistently lower than the GMI, and the big caveat is you don't have an anemia, you don't have kidney disease, you don't have something that we know that will lower the A1C. But if the A1C is always reading low, that makes this ratio high. This predicts a protection of kidney and eye disease. And this is what we learned. We learned that the glucose binding to hemoglobin, it's no different than glucose binding to the eye tissue or to the kidney tissue. It's just a window of looking how glucose binds to tissues. And so if the A1C is always reading high, that is not a good thing. And all of this is assuming that we know that the things we know that alters A1C are not there, like I mentioned. So what we found is that 64% of our patients have this glycemic ratio between 0.95 and 1.05. That's a good thing. This graph you see is the scary part. This graph was accepted for publication 2 days ago. So I have no problem showing it at all. And what you see here is you see this number 1. I'm going to actually walk over here. As this ratio goes down, as it goes down, especially once it gets below 0.9, that means that the A1C is running higher than the estimated A1C. This is what's increasing your risk of eye and kidney disease. The kidney is in the solid line, the eye disease is in the hatched line. And what doesn't make sense is why, when you have such a high ratio, why do we have an increase in kidney disease? That's a statistical artifact. That's because we didn't have many people at that part of the graph. But nevertheless, this is with over 600 people, and it's an active area of research that in Seattle at UW we are really interested in. And the point is that if you're only focused on the A1C, you may be focusing on the wrong thing. The enemy is the glucose, not the A1C. So what CGM has taught us, the enemy is the glucose, not the A1C. The take-home points, glucose monitoring has come a long way since the discovery of insulin, even prior to the discovery of insulin. CGM is now the standard of care for the treatment of people requiring insulin, and it will be more accessible for those people not on insulin. There are still major inequities for who has access to CGM, especially in the type 1 community. The future for non-invasive CGM is encouraging, and CGM is able to teach us a lot about A1C that we didn't know before, and that's what we are studying in Seattle right now. And one final point from the University of Washington, go Dogs. Thank you for your attention.
Yeah, thank you very much. Absolutely blown away, especially the history of how we are monitoring sugars and where we've come. Just absolutely blew me away. So I think next up we are going to do, we wanted to let you know, so we're going to do our panel discussion. And so I'm going to introduce our 2 other panelists here, Annika Van Sloten, who, am I right in the timing? Okay, I was like, oh no, did I mess up again? So Annika Van Sloten, she is a diabetes educator with Providence, and then Dr. Carol Weisham, who is an endocrinologist that will shortly, now no longer is. I'm just jealous with multi-care, and then Dr. Hirsch as well. So if you guys want to come on up. You do? Yeah, there's only 2 and 2 mics. Okay, hang on. Well, hopefully someone will be running and grabbing a chair real quick. If not, I'll go.
Well, you've been standing if you want to sit.
Hi, I'm good.
Okay. Perfect, Emily. Thank you. Yeah, we got one more. Yeah, you can't move these chairs in here. All right. So Annika and Dr. Weisham, would you like to say anything to start with here?
Please, Carol.
Are they on? Are the mics on?
I think so. Can you hear me okay?
Perfect.
So I have been practicing longer. Well, let's put it this way. He's been practicing on himself longer than I've been practicing in diabetes, but I have been in practice for longer than Dr. Hirsch, but have really can echo the comments that he made about the advances in management of diabetes, and can remember fighting all the fights that he describes in trying to get finger stick glucose testing covered, as well as using it in the hospital. I had nurses tell me that, well, it's just not accurate. And I'm like looking at it like, what do you think you're getting from urine testing, for God's sakes? But I mean, we were finally obviously successful at doing that. Couldn't imagine practicing diabetes without finger sticks, but now that we have CGMs, I have residents in my office, and I'm looking at, and they're going, I said, so what do you want to do? Oh, I want to start them on some basal insulin. I'm like, yeah, I want to put a CGM on them and see where their problem is, because I don't know where their problem is. And we frequently find, yeah, they have a high A1C, but lo and behold, they have low blood sugars at night and really high blood sugars after meals, and basal insulin would have been absolutely the wrong answer. So I honestly feel that not only, I mean, especially for the patient, CGM is essential for getting good control, particularly when someone is on insulin. But I love the data that you showed that, you know, just putting a CGM on somebody so that they can learn about what goes on in their body when they eat high carbohydrate meals or they exercise, it makes a huge difference in their ability to self-manage their diabetes. So I think it's important for all patients with diabetes to have some access to CGM.
Yeah, I'm Annika. I have been in endocrinology practice since 2019. And even since 2019, the coverage changed in terms of what a big deal it was to go from needing to have testing 4 times a day and proof that they're injecting their insulin 4 times a day to be able to qualify for a CGM to injecting insulin once a day for CMS guidelines. I mean, just such a wonderful door that opened for that type of monitoring. And really, as Carol mentioned and Earl mentioned, such an empowering device. I mean, to have patients to be able to problem solve on their own. Here's what my blood sugar number does. This is what happens when I have cereal. And then the next day I had eggs, and look at the difference. And this time I went and had exercise after my meal, or I led it with low carbs. Like, just the amount of gaming that a patient can do and see the difference that it makes in terms of those self-care behaviors is a really empowering device to be able to make those decisions between when you see me every 3 months. So it's just a fantastic tool.
All right, so we'd like to open it up for questions here, and we'll do, again, I'll try to repeat the questions here in the room, and then we will also have some questions from the folks on Zoom. We're monitoring the chat, and then they're going to text it to me, so I'll look at my phone and see what's there. So anyone, any questions? Okay, go ahead, right in the middle.
I have type 2 diabetes. I do not take insulin. My A1C has been a little over 7 for a couple of years, and I've got back down below 7 for a while anyway. And but one of the things that I did recently was I got a sample of CGM and wore it for the 10, 12 days that it lasted. And I was like, oh, I've got to have one of these because it was so informative. And my control was just great. I mean, I would have no problem if I had one of these things, even though I'm not on insulin. But the problem was that not only would my insurance not cover it, since I wasn't on insulin, but even when I offered to pay for it out of pocket, they seemed to get confused with, your insurance won't do this, so we're not giving it to you. So, well, I'll pay for it out of pocket. Well, your insurance has turned you down. You know, I just ran into this bureaucracy of people who just didn't get it, that I was willing to pay for it out of pocket. And I don't know if I can do that for very long, but, you know, just even for a few months, I would gain a lot of education on my diet. So, I don't know, it looks like it may be coming. And in fact, I've seen ads for, you don't need a prescription, you can go get your CGM now. But I saw them online, I thought, I don't know. So I don't know where right now to go get one and, what my best plan
So
is.
if you have commercial insurance and you can get a prescription, the best place to go, if you're willing to pay cash, would be someplace it's a big box. Like, I usually recommend Costco.
Costco.
And they're about between $65 and $70 per sensor. And yeah, they're used to having people buy them from cash. I have a large number of patients who are not on insulin who are buying their CGMs. Say that, if you talk nicer, 33? There is actually, I misspoke. If you have commercial insurance, you can actually get them for around $75 or $66 through the Freestyle Libre has a specific coupon that is available. And I think Costco will actually apply it. You don't even have to have the coupon with you.
So get a prescription, go to Costco.
Yeah.
The other option is the over-the-counter ones. So Stelio is the one that came out from Dexcom. It got FDA approved in August. You have to go directly through their website, though. So it's called stelo.dexcom.org. You buy a subscription. It's, I believe, $90. Maybe there's a promotion for $80 where you can get two or three. For that price. You don't need a prescription in that case, but you do have to go directly through the website. The other over-the-counter sensor that was FDA approved last year, it's called the Rio. I have not yet seen it in marketplaces yet. Anybody?
The
else?
lingo.
Lingo.
Yeah,
Yes,
yeah.
thank you.
Lingo.
About the same price as that too. So those
Seems
are
like we have more advocacy to do as physicians, that we, again, need to continue to work to make sure our patients are heard. Other questions here? I guess we're not getting a ton online, so happy to take more here. Go ahead.
Yeah, so Dr. Hirsch, you talked a lot about non-invasives. The other end of that spectrum is implantables. Do you have thoughts or opinions about, where the future of CGMs are going to go in terms of, non-invasive versus implantable long-term?
Right. Those are two ends of the spectrum. The Senseonics sensor has an important niche. It's not for everyone. Over the years, I've taken care of two UW women's softball players and one Seattle Seahawk. He only got to the taxi squad, so he never actually made it into a game. But they could not wear the CGM. I wish we would have had the implantable Senseonics for them. We didn't have it yet. I do think that there are people who will do well with it. I was actually talking to the dad of a 24-year-old the other day, and he being the 24-year-old, will not wear the Libre or the Dexcom. He's not on a pump, and he's going to be getting the Senseonics. He just doesn't want it. And there are issues with tape, adhesion, allergies, all kinds of things, and hopefully this will work out. So I am glad we have the option. It's an important option for certain people. I know that the Senseonics at some point, hopefully in the near future, will communicate as to be part of the AID systems. I think that's a good thing. And with all that being said, and I hope they stay around for a long, long time, most of my patients are really happy with what they have right now. Really happy.
Yeah, especially if they remember the finger sticks and other things, yeah. Yep, I too. Are there other questions here? Go ahead.
What do you see as the future for preventing neuropathy in long-term diabetes type 1?
For preventing it,
Preventing neuropathy.
well, we know, I mean, from that study, the DCCT, glucose control in those, especially in those first years after diagnosis, is the most important thing. In the DCCT, we called it metabolic memory, because what we saw is that for people who developed neuropathy, retinopathy, or kidney disease in those first 6.5 years, early in their course, that they had those problems for decades to come. And this is really tough, because if you're dealing with a newly diagnosed 15-year-old or even a newly diagnosed 22-year-old, that's very different than dealing with a newly diagnosed 42-year-old. It's just, you know, not everybody, especially in those adolescent, young adult years, take this as seriously. Neuropathy, though, there are other things that we just don't understand, why some people get into such problems with it and other people don't. I mean, there are a lot of toxins in the environment we don't understand. To me, what's the most interesting thing is when you look at neuropathy in people without diabetes. 50% of the people with neuropathy without diabetes, there's no etiology found. Nobody can figure out why. And there are a lot of reasons, chemicals, chemotherapy, all kinds of things we know that do it. But neuropathy is sort of still a big question mark to me, because if 50% of people with neuropathy without diabetes, we can't figure out why, that makes it really tough if you do have diabetes.
Yeah, I think I really concur with what Earl said. It's multifactorial, but I always try to encourage people, if they have diabetes and develop neuropathy, that they need to know that it goes beyond glucose in many, if not most of those cases, and that they shouldn't, feel like they failed in managing their diabetes. So, avoiding alcohol, avoiding chemotherapy if you can, and just trying to eat lower inflammatory type of foods, and eat healthy, keep your cholesterol under control. I think all those are really important for trying to prevent neuropathy if you have diabetes.
What's really interesting is that if you look under the microscope at neuropathy from alcohol and neuropathy from diabetes, it's identical. It's identical. And so for people who have bad neuropathy, who are heavy drinkers, that's like the worst thing you can do.
I have a question about retinopathy. I hope I pronounced it correctly.
Yeah.
You have a question about it?
Have you prevented any?
How do you prevent diabetic retinopathy?
Yeah.
Well, I mean, this is really where glucose control, especially in those first 10 years after diagnosis, this is no matter if type 1 or type 2, is critical. What we've learned is that for people who have minimal to no retinopathy after 20 or 25 years, depending on the study, if you don't have retinopathy after that long of a period of time, it's unlikely you are going to get it. Now, involved with retinopathy is blood pressure control, and poorly controlled blood pressures with poorly controlled blood sugars are not a good thing. What's really interesting to me when you look at the studies is that smoking seems to be a risk, and I hope I have this right. Smoking is a risk with the kidneys, but not a risk with the eyes, when you look at these big epidemiologic studies. But the big thing is the glucose control. What one of my interests was for many years, it's still an interest, but we're not going to be able to get the right kind of data for it, is how dangerous are the ups and the downs of the blood sugars to the eyes. I personally think it's not a good thing, but the problem is we can't do the right kind of randomized controlled trial. It would be unethical to do it today the way I would do it. Keeping the GMI or the A1C the same, and then one group going like this and another group going like this. So your question is very good. It's a huge public health problem, which is why maybe the most important thing to take away is regular eye exams. Really important.
And I do think too, Earl, it goes back to that time and range being a better indicator sometimes than A1C, because you can have a reasonable A1C, but your numbers can be 440. And I mean, that level of swinging that's tough on the eye, that really gets picked up much quicker and can be intervened much more nuanced on a CGM device than purely through a lab draw.
I think the point that I frequently make with my patients is they come in and they've been in chronic poor control, and I call it finding Jesus. They find what they need to do to get their glucose under control, and then bam, 5 years later, they're diagnosed with retinopathy, and it's really discouraging. It is really important, as Earl said, is the probably most important time for prevention of complications is shortly after diagnosis, and that's the time where people are, oftentimes struggling to get the care that they need, as well as to accept what they need to do to take good care of themselves. And so that, to me, you can get complications 20 years after you get your diabetes under control, just based upon the duration of poor control that preceded that time. So getting on top of things as quickly as possible. If you have prediabetes, continue the efforts to prevent diabetes and keep screening for when you make that cross that threshold, so that you can maintain excellent glucose control for the duration.
I want to make one other point on something Carol said that's so important. And it doesn't matter how you got there, but we learned in the early 1980s that if you have a high A1C and you bring it down real fast, if you had a little bit of retinopathy with that high A1C, you can get a lot of retinopathy after you bring it down fast. And there's a lot to this. It doesn't matter if you're type 1 on insulin or if you're type 2 and you do it with Ozempic. It doesn't matter. It's shocking the retinas and bringing the blood sugars down quickly. And we have seen a lot of this over the years. In fact, I had a patient literally just a year ago. It was a lady with type 2 diabetes. She didn't know she had diabetes. I knew her husband. Her husband brought her in. Her A1C was 12. And undiagnosed diabetes after her heart attack. And she had in the hospital, they put her on insulin. They put her on insulin and they put her on a couple of other drugs. And her GMI on her CGM was, after two or 3 weeks, it was like 6. And she started with this A1C of 12. I said, you've got to get to the eye doctor right away. This was on a Friday afternoon. On Monday, she was in the eye doctor, and she had these things in her eyes called cotton wool exudates. And this was just a few weeks after she started it. And so I put the decelerator on, bringing all the blood sugars back up because I knew she came down quickly. And what was interesting is 6 weeks later, now I should have published this because I didn't know it. Nobody knows how fast this happened. 6 weeks later, those cotton wool exudates were gone.
I think it's still more important to get your glucose under control, because not too many people start at 12 and go to 6 in 2 weeks. I don't want to discourage you from getting your glucose under control. And the DCCT study showed that those people that got retinopathy with a quick improvement in their glucose still were better off 2 years down the road than the people that did not get their glucose under control.
Very true.
But we have seen individual cases, not for a population like we've seen individual cases where people have lost their eyesight, unfortunately.
I've never seen it.
I have. I have seen it. And the other thing, which there will be data presented at ADA, not my data, in Chicago, an A1C of 19%. I've never seen one that high.
I have.
Wow.
You have 16
Once.
is my max.
I've worked in some underserved areas with challenging access to care, and I don't think I've seen 19. That's amazing.
But I'd tiptoe with that 19 patient. I would definitely tiptoe in their glucose control.
We had a question from the online folks here, and it's when should someone with type 2 diabetes switch from using a stick to using a CGM implanted device? Is there any data on when is the best time, or at what point would you consider doing that? Or when can you get it covered?
I want to make sure I understand. A CGM implanted, are we talking specifically Senseonics?
I think they just mean a
CGM.
regular CGM device, sorry.
Oh, well, I can give my answer. I think everybody should be on CGM.
Today.
Yeah,
Yeah.
I mean, I don't think there's any reason to wait.
Yeah.
I mean, to me, that's a pretty easy one based on what we've learned.
So there's lots of different answers to that question. One is what's covered and realistic because of that. I think everybody can get access to a professional CGM, and at least one of the companies that makes it allows you to see real time so that you can say, I'm newly diagnosed with diabetes, let's put a professional CGM. That can be covered. You've got 10 days or 2 weeks or whatever of data that you can actually start applying what you're learning in diabetes education and learn to take better care of yourself. And you can have one of those maybe as often as every 3 months. So that's an option for if you can't get your insurance company to give you one that you take home and wear personally, you can still get access to the information. I think is really important. I love using CGM in those patients in whom, all right, these other meds aren't working. Let's just see where the problem is and what would be the best next step. And then finally, those patients getting started on insulin, all Medicare, and some commercial insurances will cover it in that setting, and I use it to start and titrate the basal insulin. And then all patients with type 1, standard of care, hands down, everyone should have it no matter what.
I think it's important to mention too, as we're talking about coverage, through Medicare, it's a DME benefit. So if your primary care physician sends it to the pharmacy, it will not be covered under Medicare insurance unless you have a specific thing through your Part D for that type of coverage. It has to go through a DME like Byram or Edge Park or something like that in order for that to be covered under your Medicare benefits. So I think that is an important distinction. In the Medicare, it's a very Medicare specific thing.
So DME, durable medical equipment, that's very similar to, like, say, if we were prescribing oxygen for someone with emphysema, it goes through a DME provider. You can send it to the pharmacy and it'll I don't know where it goes. They just, like, out into the ether probably.
And some Medicare Advantages actually go through the pharmacy, and I've seen people switch from Medicare Advantage, they're getting through the pharmacy, and then they go back to the pharmacy after they switch, and the pharmacies don't always understand that a change in insurance is the reason why Medicare is denying their pharmacy plan. So if you are used to getting the pharmacy and suddenly you can't get it covered, it's probably because your insurance now wants you to go to a durable medical equipment. So don't take no for an answer. Go back and find out how your provider can send you perhaps to a different place to get your CGM.
And I'll try to repeat the question too so they can hear online.
I wanted to revisit the ranges for the CVs. What's the good and the bad and the ugly again? The ugly was above 3.6?
Yeah, it's,
So the question is about what's the ranges on the CVs, the good, the bad, and the ugly, and about 3.6. Did I remember that?
yeah,
right?
36. So when there's a investigator from France, his name is Louis Monnier, and he's the one who said, we need to get it below 36. And then I came out and said, well, that's too high because there's too much hypoglycemia in type 1 diabetes at 36. And we looked at our data and we said, 33 is a better number. We then went back and we actually published this, and both of those are wrong. What we learned is that since the CV is based on the mean glucose, you can't look at CV by itself. It's actually based on what the average glucose is. And so I'm not even sure looking at the CV makes any sense. I think it's better to look at time below range, because we're really using it as a surrogate for C-peptide, a surrogate for hypoglycemia, a surrogate for patient behaviors if they're trying to defend in a type 1. We're using it for all these other things, but not necessarily what we thought we would do to look at the variability based on the risk for hypoglycemia. Now we can just look at time below range and get that.
think I'm going to come over here. Go.
I'm curious what your thoughts are on pancreas replacement or islet cell therapy, like what you think an ideal candidate would be or what outcomes you've seen from those things.
So the question is about pancreatic replacement or islet cell replacement therapy and the ideal candidate, and maybe if you've seen some outcomes. Say that right?
You want me to start? Or
You can start, yeah.
I'll start. Well, when I was, the summer before I started medical school, I worked in a lab of Dr. Paul Lacey
Oh, Lacey.
and David Sharp. And we were doing xenotransplants going from mouse to rat with islets. And I was the one isolating the islets with someone by the name of Denise Faustman. Yes, I'm really dating myself. And Dr. Lacey said, we will have this in humans in 5 years. This was the summer of 1980. And I learned a lot. And what I also learned is don't necessarily believe everything you hear from a researcher trying to get grant money. Because we've learned a lot. If I look where we have come with the stem cell therapy, I was cleaning out my inbox on my email, and I found these emails from ViaCyte from 15 years ago. Now, ViaCyte, of course, is now part of Vertex, and what they're doing is extremely exciting. The big issue right now, however, is the immunosuppression. And I can't speak for anybody else, but I have seen what happens after 10, 20 years of immunosuppression. It's not good. And especially if you are dealing with, you have the tools with automated insulin delivery, you have the CGM, and you have the resources, your insurance pays for it. The way we do diabetes now compared to 1980, you can't even compare. And so I'm very excited about the research. I hope the stem cells work, the islet cells, there are other companies working on it. And like the non-invasive CGM, there are so many people working on it. It's a very exciting time. But with that being said, it's the immunosuppression that gives me pause. And my final comment is we are also looking at intrathecal leptin, having leptin in the brain. And the reason why we're so excited about that, if you take a type 1 animal and can get the leptin directly into the brain, they don't need insulin. So these are the things we're working on. I'm very excited about it, which is why I don't have any plans to retire anytime soon.
He's not seeing patients anymore. Don't let him fool you.
That's very true.
So to answer your question, a person for currently available islet cell replacement would be somebody whose quality of life is so awful because of hypo or hyperglycemia that it makes it worth considering this treatment. And then the other population are people who've already on immunosuppression for other organ transplants who have access to islet cells or to partial pancreas, to pancreas transplants. I am extraordinarily excited about the rate of improvement in technology that have happened in islet cell replacement. It's true, right now, all of the studies that have been done still are doing studies with patients requiring immunosuppression. But now we have access to potentially limitless numbers of islet cells, which was one of the big barriers before. And many companies are looking at ways at helping to develop almost like little pods of islet cells that are protected by a film that can protect the islet cells from having or from the immune cells having access to the islet cells. We don't know what it's going to look like when it becomes available on a larger scale, but I do think it is going to be an option for patients. But, technology versus biology at this point, I don't know what's going to win.
Okay. Wow. Yeah, stuff keeps kind of blowing me away a little bit. I think we'll go in the front here and then in the back. So go ahead.
What is your favorite way to explain the difference between a finger stick glucose value and a sensor value? When patients talk about their
So the question is, like, what's your favorite way to explain the difference between a finger stick and a sensor or a CGM value for patients?
We'll let the educator
Yeah, who does this all the time,
educates
right?
better than we do.
I really like the front and the back of the train, right? So if you got a train, and you got the front of the train and the back of the train, if your blood sugar is relatively level, right, those levels are gonna be pretty similar. That lag time isn't gonna show up quite as much. If you're swinging, right, there can be a pretty big difference between the front and the back train, as I was gonna read. So if you are looking at that lag and your blood sugar is diving like this, so there's gonna be a pretty significant difference potentially between that finger stick meter and what that interstitial fluid is reading if you're going down or you're going up. So that's kind of, I think that's a helpful visual when you're talking with patients about it, because it does kind of freak them out because you're making decisions based on that number. But the arrows are also a great indicator in that, right? So it helps sort of mitigate some of that panic surrounding that decision.
I would add, I like the analogy. There are a couple of other things to think about. Blood glucose, you are measuring blood. CGM, you're measuring interstitial glucose. So you're measuring two different things. So that's point number one. Point number two is that and we went through an entire several decade-long controversy about how accurate does the finger stick glucose need to be. And as it turns out, depending on what meter you are using, they are not all the same, and they have their own inherent inaccuracies. And you may actually, you're assuming that the finger stick is spot on, that's the reference. It may be way off, and the CGM may be spot on. You don't know since you're not sitting there next to a regular lab. And so there are all these other things. It's obviously a complicated discussion.
I'd like to add one other point, is that the labs and the accuracy are done, I mean, the accuracy data that are generated are done in a lab where everybody is doing everything perfectly. And I always tell my patients, you have a greater chance of screwing up your finger stick and making it inaccurate compared to the CGM being inaccurate.
That's interesting. One of our online questions was actually just about that, about how important it is to verify a CGM reading, and I would say clearly not important. In the back. Yep.
Wait.
Oh, sorry.
Yes.
One more.
Except if a person feels low and their CGM doesn't show low,
Right.
or vice versa, it shows low and they don't feel low, to try to make sure
Confirm.
that they're corroborating that data.
Perfect.
Compression lows.
Yeah. All right, go ahead.
Yeah.
When you were talking about the islets and the immunosuppressive drugs, that's Vertex's 880.
That's right. Very good.
Yes. Do you know whether, because I can't find it online, Lonza and Vertex are building that huge plant, 130,000 square feet in Portsmouth, New Hampshire. But I can't find out anything there because they have the VX264, which
Wow.
has got the shield on it.
That's right.
Yes.
Very good.
And I can't find out if they're, I'm an old guy. If they get that going, I would really like to be part of it. But, because they only had, 12 people in the VX880 study, something like that.
So the question is, you'd like to find out if they're making this, or where are they making it?
Well, I want to find out what's going on with that plant in Portsmouth, New Hampshire.
The question is, what's going on with the plant in Portsmouth, New Hampshire, from Vertex
I am not a
Pharmaceuticals?
press agent for Vertex, so, nobody has shared that information with me. I wish I knew.
I am a lowly family doc from Newport, and I have no idea. That's for sure. I think we had an online question I wanted to go back to. There were lots of them. There's a question about anemia impacting type 1 diabetes, and the person just wanted to learn a little bit more of that, of how anemia would impact type 1 diabetes. I think that was probably in reference to your slide looking at A1C and the effect of anemia on an A1C.
Yeah, there's a lot of things to talk about anemia. And as it turns out with A1C, like everything, it's complicated. Most of the anemias that we see will make the A1C level falsely low, most of them. There are many, many reasons one gets anemia. What's the most common reason for anemia in the United States? Yeah, well, one of them, iron deficiency. There was an article in JAMA, it was like 60 million women with iron deficiency anemia through their reproductive years. As it turns out, iron deficiency causes a falsely increase amount of the measurement of A1C. And what's so interesting, there was an article published in 1999, I show the medical students that when you treat the iron deficiency, you can actually make the A1C lower. And in fact, they took people without diabetes and they cured the diabetes by treating the iron deficiency because the A1Cs were high, but they were falsely high. And so if you have an anemia, you have to look at that A1C with a salt tablet. And as a matter of fact, somebody who's having anemia going up and down, and we see this a lot with our GI bleeders, where their anemia, the anemia is treated, or maybe they get transfused, and then they have another GI bleed, and then they have anemia on top of that because this is all from cirrhosis and end-stage liver disease. It's just really, really tough to make any sense of that A1C. But despite that, Medicare wants that A1C no matter what.
No matter what.
For you, every 6 months. Although HEDIS, now this-
HEDIS.
HEDIS. Recently, and this is brand new, well, it's a year and a half old maybe. Some of them are now accepting GMIs from the CGM, okay? Which in some respects may be the more important one to look at. But that's recent, and Medicare I don't think accepts GMI. You have to have that A1C, or Byram or EdgePark or whoever, they won't send you your next set of CGMs.
Yeah, that's what you need it for, yeah. For that and your-
Whether you're anemic or not, they don't care.
All right, well, I think we are about out of time, so I think I'm going to go ahead and wrap up. And first, I'd just like to thank our panelists and Dr. Hirsch for coming and speaking to us. Absolutely fantastic. Thank you all.